Hi there, we're going to have our last lecture on cardiac for Bio 232. What we need to do is we're going to be looking at a couple different things today. We're going to be looking at our lecture notes. We're going to be looking at a document that I have up on Moodle, which is taking some of those lecture notes and kind of rewriting them in a way that I think is a little bit better. And then we're also going to look at some diagrams in the book. So lots to look at today. So let's switch over to the lecture notes. So we finished up ECGs, and we're going to still talk about ECGs in a minute when we're talking about the cardiac cycle, because what we want to think about is what's happening through one entire heartbeat process. Okay, and if we can figure out how the heart is working completely through one process, that gives us a lot of insight into a lot of different things. So we can understand when the ECG is active, we can understand what's happening at each phase of the ECG, we can understand when valves are opening and closing, when blood is moving from one chamber to another, and kind of how the whole process works. So that's what we're going to look at today. So we're going to start with a full cardiac cycle and talk about what that means. So first, some term definition. Systole is the contraction of the heart. Diastole is the relaxation of the heart. All right, so you've maybe heard of systolic and diastolic. We talk about blood pressure. So there you go. Systole, contraction of the heart. Diastole, relaxation of the heart. The cardiac cycle is one complete heartbeat. So this means that both the atria contract and relax, and the ventricles contract and relax one time. That's cardiac cycle. Okay, now what we're going to look at in a lot of detail today is we're going to go over to the book and look on pages 694. I'm going to put this up here so you can, and 695. And these are one of these focus figures, and it talks about the cardiac cycle. And the nice thing about it is it gives a visual representation of everything that's happening all at the same time. And so what you can do is you kind of look at the graph at any given point and know exactly what should be happening. The numbers that you see here, the 1, the 2, the 3 right here, and 4 right here, refer to the 4 different phases that you're going to see on that graph. Okay, so why don't we go over to that picture and graph, and then we'll come back and kind of go back and forth. Okay, so there's 2 pages to this. The first is right here. This is talking about how they're setting up what they're about to show you. And so it says the cardiac cycle consists of events during a heartbeat, and we can measure bunches of different things and understand what's happening. So it says let's measure the pressures in the left atrium, left ventricle, and aorta. So remember, those are pressures that are going to be pushing blood down to the ventricle, and the ventricle is going to push it out to the body. And then we want to see, once it's in the aorta, what the pressures are as well. We'd have lower pressure values, obviously, on the right side because it's not as strong, it's not pushing as far. These also are going to correlate a little bit to our blood pressure, which is one of the reasons that they're using this. Okay, so what you do is during an entire heartbeat, you're watching the pressure change. So the reddish purple line here is the left atrium. All right, and so you can see pressure goes up and down and up and down. Okay, and then you see also the left ventricle goes up slightly and then goes up dramatically and then comes back down. Then we have the aorta. Pressure is very low, dropping off, and then pressure goes up. Now, what's happening at each of these places? Well, right during here, this phase here is where we have atrial contraction. We'll talk about that in a minute. And the atria contracts and increases pressure briefly in itself and the ventricles. And then the ventricles contract, okay? And as the ventricles contract and eject blood, pressure goes up in the ventricle. At the same time, as soon as blood is ejected from the heart, pressure goes up in the aorta and kind of matches it. And then things fall back off, and we'll talk about this little guy in a minute. So that's kind of what's happening there. And you can read, it shows you where the valves are closing and the valves are opening. We'll get to that in a minute. What I want to show you now or the second part here is they also have the heart sounds here. And you have the same picture kind of with these 2 pages all put together on page 12 of your lecture notes. And the heart sounds are up near the top. The heart sounds are when the AV valves close and the semilunar valves close. So this first sound there is going to be during this phase, and the second sound during that phase. All right? And we'll talk about those also in a minute. Where we're going to spend most of our time on this diagram, let me zoom back out so we can get to the other one, is this whole guy here. And this particular part of it shows not only what we were just talking about in the center, all the different pressures, but it's looking at 3 other things here. One is we're looking at the volume of the ventricle. How much blood is in the ventricle during filling, contraction, and ejection of blood. And then another cycle starts over and filling again begins again. So we'll talk about that. And then up here is a stretched out ECG. It's stretched out so we can see very clearly what's happening while these things are happening. So we have our P wave, our QRS wave, and our T wave. So, and then lastly at the bottom, we have pictures that tell you where the blood is going, what is happening to the blood, when it's ejecting, and the names of those phases down here. And here's those numbers I referred to earlier. Number 1, number 2, number 3, and number 4. Okay. So, lots to look at. Now, the way this works is this is time. Our x-axis here is time. So at any given moment, if we go up and we look at something, we can see what the volume is. We can look where the pressures are of all of the places we're looking at. And we can see where we are exactly in the ECG. So it's a really handy graph to kind of understand the whole process. So let's go back and look at our notes, and then we'll kind of jump back here, and we'll kind of go back and forth as we talk about things. So the number 1 is the period of ventricular filling, all right? So the heart is relaxing. It's really at the end of a contraction period. So we're into mid to late diastole. Both the atria and ventricles are relaxed. Now, when blood returns from the whole body to the right atria, most of the blood just goes into the atria from the superior vena cava and the inferior vena cava, and a little bit of blood also from the coronary sinus. And that blood just goes straight down and drops through the right AV valve into the ventricle. Okay, because both are relaxed and that AV valve is open, the ventricles fill about 70%. So about 70% of the blood does this exact thing. It just kind of passively drops down. Now, and so let's look at that on our picture here. So so what are we gonna look for? So first we're gonna look at pressure. So here, this part right here, this beginning part is this first part here, is blood is just passively dropping into the ventricle, and this is ventricular volume. So for a little period of time here, we get filling slowly of blood in the ventricle as blood just drops down from the atria. Pressure both in the atria and the ventricle go up because as we increase blood into a chamber, it pushes on the walls and it increases the pressure a little bit. Now, we get a P wave. And remember, P wave is the depolarization across the atria. And about, if you kind of drew a line straight up about halfway, right about there of the P wave, we start to see contraction occurring. And that's what it says down at the bottom here, atrial contraction right there. And so as we see this contraction, we get a little bump as any extra blood that's still in the atria is forced now into the ventricle. And this gives a little pressure bump as we reduce the volume of the atria and push blood. And that's what that says. The rise of pressure is caused by atrial contraction. Right? Can you see that there? And then the atria start to relax and there's no more blood in them, so the pressure drops off. The ventricle also doesn't have any more blood being forced in, and so its pressure drops off. And notice it plateaus. The amount of volume that's here is now going to stay in that ventricle until we inject it. All right, so that's step 1. We have both passive dropping of blood in here, on the right side and on the left side. Blood just goes in passively, coming back from the lungs, coming back from the body, and we get filling passively. And then we start to have contraction, and those little arrows there on either side are showing contraction of the blood into the two ventricles. Okay? All right, let's go back and look at what's happening there. So the remaining, so when we get contraction, we get an increase in atrial pressure, that little bump you saw, that delivers the remaining 30% of the blood to the ventricles. Now the atria and diastole for the remainder of cardiac cycle, they're going to repolarize behind the QRS wave, and they're going to get to relax until they have to contract again about a second later. Now we're going to start talking about ventricular systole, all right, where we're going to get contraction. So we get ventricular depolarization. Remember, and it's a little hard to read there, but that says QRS. So if you need to write that a little better, QRS. That's going to start the process to contract the ventricles. Now remember, there's always a lag, because once we send a message from the AV node down the different bundle branches and out the Purkinje fibers, there's going to be a slight lag in time as the contraction starts at the apex and goes upward. Okay, so if we look over, what will happen is, so we're going to do that contraction. That contraction is going to close the AV valves, and then for a brief moment in time, all valves are closed, and this is called a closed chamber and causes isovolumetric contraction. Okay, so as we contract the ventricles, the pressure increases. This closes the AV valves, right? Because blood gets forced upward and those valves lock in place. Now all the valves are closed, and we call this a closed chamber, and we get our second step, isovolumetric contraction. Okay, so now let's look at that and kind of talk about some of the things we just mentioned there. So isovolumetric contraction here is closing these valves. That's what those arrows are pointing to. So we start to get contraction of the walls, and that closes the valves. But notice this is only a very brief period of time here. And also notice that every valve, all 4 valves, are closed right now. This is the closed chamber. So now let's go up. So it's this darker orangey color, brownish orange, okay? So we have the ventricles are filled with maximal blood, about 120 milliliters of blood, and pressure is starting to go up. And the reason pressure is going up is because we're starting to shrink the ventricle by contraction, but no blood's been ejected yet. And blood doesn't get injected until right at this point right here. So where are we in the ECG? Well, here's our Q, here's our R, all right? And at R is when we start the contraction. We've moved enough down towards enough of the electrical impulse down towards the apex that we start to get slight contraction. Here's the S, and right after the S happens, we start to actually get ejection occurring right at this point, okay? So right here, this little spot is a closed chamber. All valves are closed. No blood has left the ventricle, but it's about to. And soon as pressure gets high enough, the semilunar valves will open and blood will go into the aorta, which is why you see this green thing going up. So let's go back and take a look at that on our notes. So it says, just to continue here, the isovolumetric contraction phase will increase pressure in the ventricles very quickly until blood is ejected into the aorta and pulmonary trunk. And this is referred to as the ventricular ejection phase, number 3. Now the pressures that we're going to see in the aorta and the trunk are very different. And if you remember, we talked about our systemic blood pressure being about 120 millimeters of mercury over 80 millimeters mercury. That 120 is systole, during contraction. This is maximal pressure, the pressure that the heart is exerting on the walls of the vessels during contraction. So we see something like 120 millimeters of mercury. Now in the pulmonary trunk, it should be 25 millimeters of mercury. Remember, it's a much lower circuit. The muscle in the right ventricle is much less strong and thick, and we don't need to pump it as far. We only need to pump it about 6 inches to go from the heart to the lungs. So we're much lower, about 25 millimeters of mercury. Now, let's go ahead and go back and look at that and kind of verify what I just said. So pressure, so right here is when the semilunar valves are going to open. So we call this the ventricular ejection phase, and that's this part right here. So a couple things are going to happen. One is blood is going to leave the ventricle, and that's what we're seeing as blood goes out of the ventricle. Okay. Now we have a name for this, and we're going to talk about this in a little bit. The difference between the blood in the ventricle and the blood left over at the end, because we don't eject all the blood when we contract. Some blood is left. Okay. We don't when the contraction occurs, some blood stays in the ventricle. So we go from about 120 to about 50 milliliters. That difference, which is 70 milliliters, is what we call stroke volume. And that just means every stroke or beat of the heart, how much blood is ejected from one of the ventricles. Each ventricle is about the same, so you can just measure one. So if we're measuring the left here, it's about 70 milliliters, so that's fine. That's how much blood is being ejected from the left side of the heart. It's pretty much the same on the right side. Okay, so first we're getting rid of that blood, and not getting rid of it, but ejecting that blood. And so while we eject blood, it goes into the aorta, because remember, we're looking at the left side here only in this graph. And so the aortic pressure goes up very dramatically, as does the ventricle pressure as we squeeze and contract the ventricle. And it peaks at our maximal blood pressure. And so for a normal person, this might be 120 millimeters of mercury. All right, and that millimeters of mercury is just an old way of measuring, where they had an actual column of mercury and they applied pressure to that column and it raised up the column so many millimeters, and they measured it that way. We don't do it that way anymore. We don't use mercury. It's a toxic chemical, but we still use those units. So we convert other pressures into millimeters of mercury. So at about midway through this ejection phase, we get to maximal pressure. And then pressure starts to drop off as less blood is being ejected out of the ventricles, and the aorta is moving that blood on through the system. Okay? So that goes all the way to about here, and notice what happens. That is going to continue after the S wave all the way to about halfway through the T wave. So repolarization is already starting on parts of the ventricle as we're finishing the contraction at other parts. That kind of makes sense, because it kind of contracts as a wave, the heart, and so it starts at the apex and twists up. The apex can start relaxing a little bit earlier than the top tissue can. All right, so now let's go back and look at this last phase, which is this one here. Okay. Switch over, and so we call this last phase the isovolumetric relaxation phase. Early ventricular diastole, which is relaxation, right? So pressure in the ventricular pressure, the pressure in the ventricles is dropping. And so a couple different things happen. As that pressure goes down, we've ejected blood into the aorta, right? And the aorta, if you recall, is a structure that looks kind of like that. And we're ejecting, we have semilunar valves here, and we're ejecting blood like this, okay? And so a lot of the blood goes that way and goes up to our vessels that are brachiocephalic artery and whatnot there. But as pressure drops down here in the ventricle, this is all now filled with blood. There's just a whole bit of blood in here. And so gravity wants to take the blood that's right here, and it wants to have it go back into the ventricle. But we don't want that. We don't want it to go back in the ventricle. We want it to stay in the aorta and continue and go through the system. So as blood drops back down due to gravity and low pressure here, the semilunar valves will close and the blood will be stopped right there. Okay? That's our second heart sound. The first heart sound was when the AV valves closed. All right. The second heart sound is when the semilunar valves close, both the pulmonary and the aortic ones. We're only looking at the aortic ones here. So if we get backflow of blood into the aorta and pulmonary trunk, this change of pressure within the ventricles and gravity allows the blood to move back into the ventricle from the aorta, and this closes the semilunar valves. All valves are closed again at this point, and so we have another closed chamber, and we call this isovolumetric relaxation. Think of that word for a minute. Iso means same volume, same measure of volume, relaxation, which basically is meaning that no blood is going into or out of the ventricle at this moment, and the ventricle's in relaxation. Up here, we had isovolumetric contraction, and at that point, we were starting to contract the ventricle, but for a brief period, no blood was leaving the ventricle and no blood was coming into the ventricle because all the valves were closed. Okay? Now, so let's go back and look at that real quickly. So during this phase here, the aortic pressure drops, blood from the aorta wants to go back into the ventricles, and that causes the ventricles to the semilunar valves to close here, and pressure will really drop off in the ventricle until about this point. And at this point, we are going to start this whole cycle over again, and we'll come back to that in 1 minute. All right? But I want to show you something really interesting. Notice right here, as blood goes back in the aorta and the semilunar valves close. So here I'm going to show you the picture down here. Here's the semilunar valves both closed in the aorta and in the pulmonary trunk, right there. And that's where we get our second heart sound. Well, pressure jumps up all of a sudden in the aorta, and this is because the blood went back into the aorta and closed the valves and now pushes on the walls. And so we get a brief bump. And this bump, if I were to circle this right here, is called the dicrotic notch. And that notch tells us that the semilunar valves closed and blood tried to go back in, but instead it couldn't, so it pushed on the walls. All right. The other thing to think about here is when the semilunar valves close at this point and blood rushes back in, this is when the heart is starting to relax, and those right and left coronary artery openings that are right next to the semilunar valves in the aorta can start to open and fill with blood. And so this is where we actually fill our heart with oxygenated blood, is right at this little point right here. So that's a really important step, that dicrotic notch there. Okay, now let's go back to our notes and kind of finish things up. When the aortic and semilunar valves close, but especially when the aortic valves closed, that pressure in the aorta is going to be represented by the dicrotic notch, which will be noted on, not the ECG, on the atrial waveform, the thing that we're looking at right there. Now, the one other thing is, as the ventricles keep relaxing, right, because they're in a relaxation phase, they are going to relax so much that the AV valves can open back up again. When the AV valves open back up, we can now just start this all over and start up here and say, oh, we have relaxation of both things, we're going to have passive filling, and then we'll go through our next cycle. So once you get to this point and things start to fill again and pressure has dropped and the AV valves open, now we're back over here. So the end of this is kind of like right about here, and we start the whole process over again. So this graph continues and kind of goes back on itself to the beginning and then does it again. Okay, so now, so I think this is an important graph to look at, and you can look at it here. This is our picture. It's much smaller, but everything's lined up, and you can kind of annotate it if you want, or you can go to the notes there and kind of follow it again. Now this one uses 1, 2A, 2B, 3, and it should be 1, 2, 3. Here, if you want to use it the way the book now has it, they say it like this, I believe. 4. Yeah, 1, 2, 3, 4, and then this starts over at 1 again. So that's the same numbering system. But it's an important thing to know and to look at and understand what's happening at each part of the graph. It's a really good way to learn this system well. So a couple quick things before we move on to our last topic. Average heart rate is 75 beats per minute. It could be anywhere from 60 to 80, but let's just pretend we're using that number. So each cardiac cycle requires about 0.8 of a second, right? It has to beat more than once per second. The atria are contracting for about 1/10 of a second of that, and the ventricles are contracting for about 0.3 of a second for that. So the rest of the time, about half the time, the whole heart is in relaxation, known as the quiescent period, the quiet period, right, when it's repolarizing. Now, one complete cycle means then that the atria are in systole for about 1/10 of a second and diastole for about 0.7. And then also during that 0.8, the ventricles are in systole for about 0.3 of a second and in diastole for about 0.5 of a second. So the heart does get to relax more than it gets to work, but on both parts of it, but it's working all the time. And during those relaxation periods, we need to make sure the heart is as healthy as possible, getting the oxygen, the nutrients, getting rid of waste products, everything like that. Okay, last thing was the heart sounds. And remember, the heart sounds occur here at this part of the graph and this part of the graph. And it's because it's where there's closure of valves. So we often describe these as a lubbed up, and the lub sound, which is a little larger and stronger, louder and stronger, is where the AV valves close. And then after contraction of the ventricles, we'll hear the dup, where the semilunar valves are being closed after the blood is rushing back, trying to get back into the ventricles. Okay? All right. We're going to now move on to another topic, and this will be our last topic here in the heart. So this starting here and on page 12, 13, and 14. So this page, and this page, I have rewritten those notes in a way that I think is a little easier to understand. Maybe you agree, maybe you'll disagree after you hear it. I generally don't even highlight these notes because I have written them on another handout. But you can go ahead and highlight these notes after you kind of hear everything from me. So one thing I do want to mention is this is page 688, and this talks about the parasympathetic and sympathetic fibers that innervate the heart. And so I'm going to just reference that because I'm going to talk about that, but I'm not going to show this diagram. All right. And so you could go and look at this diagram, and that might help you understand what's happening a little bit. But what I'm going to do now is I'm going to actually switch over my notes. I'm going to pause. These notes that I'm bringing up are on your Moodle on the same week that you have this lecture. And so I'm going to now move over and talk about those notes. And you can follow along with that page, or you can even follow along with these pages here, because I kind of go in the same order. I just like my orientation better. So I'll be right back. Okay, I brought up my notes that are in a PDF form. We have neural regulation of cardiac output. So we want to look at how the nervous system affects the heart. We've already mentioned that the heart will beat on its own using its pacemaker cells at about 90 to 100 beats per minute without any innervation from your brain. But as you know, you're getting innervation from your brain all the time, and your brain is regulating whether we should lower our heart rate, like when we're sleeping, or we should increase our heart rate when we're exercising. So we want to understand what it does to our heart rate and what that heart rate does to our cardiac output. Now, we haven't defined that yet, so we have to talk about cardiac output. So let's take a look at this, and we'll highlight some things. So cardiac output is the amount of blood ejected from each ventricle per minute. So remember a little bit ago I was talking about stroke volume, and I said stroke volume was the amount of blood that went out of one ventricle during one contraction. And so all cardiac output is we say, what is our heart rate per minute? how much stroke volume is going out on average each heartbeat. Multiply those together and we get cardiac output, okay? So cardiac output gets simplified to heart rate times stroke volume. That's the equation. So, and we'll do an example in just a second, okay? So we'll make it make sense, all right? But what we're doing is we're saying how much blood is going out of one of the ventricles, because remember, they're about equal. So we usually use the left side, but we could use either in a minute's time. Now remember that the stroke volume, though, was the difference of blood that entered the ventricle during diastole, all right, during relaxation, and then the atria contracts, but remember the ventricle's still in relaxation. So that's the high amount of, the highest number of amount of blood that's there, okay? And we call that end diastolic volume because it's the volume at the end of distally of the ventricle. And then the ventricle contracts and enters systole and ejects blood. Well, it doesn't eject all the blood, and so any blood left over is called the end systolic volume, ESV. So stroke volume is the difference of the blood entering a ventricle during distally, which is called end diastolic volume, or EDV, and we then subtract from that the blood left in the ventricle after systole, after contraction, and this is called end systolic volume, okay? Generally, only about 60% of the blood is pumped out, so blood remains, and that's okay. That's normal. All right, let's do an equation here and see if we can figure this out. So we can first make this slightly more complicated by substituting for stroke volume EDV minus ESV, the things that I just said. The high number of volume of blood in the ventricle minus what's left over after contraction. Okay, so now let's do a quick calculation. And generally speaking, we won't make you do calculations on the exam, on the lecture exam, but you need to understand how these relate to each other, and if we increased one, what would that do for cardiac output? So let's say we have our 75 beats per minute, all right, and we'll use the values that were in our example from the cardiac. We had about 120 mils in our maximally in our ventricle, EDV, and we ejected all but 50 mils. 50 mils remained in our ESV. So now all we do is we substitute all those numbers in. So we say 75 times 120 minus 50. So you'll have to do the parenthesis first. 70, 75 times 70 is a little over 5,000 mils of blood per minute. That's our cardiac output. That's a pretty normal cardiac output for your just normal waking moments. So what does this mean? And so now what we want to do is we want to start thinking about how, if we change this, what would happen. So anything that increases heart rate would increase cardiac output, right? Let's say I change this number to 80. 80 times 70 is 5,600. So cardiac output just went up. So anytime I increase heart rate, cardiac output goes up. Okay, now let's say I increase stroke volume. Total stroke volume is now 100. Well, now my cardiac output is 7,500. So stroke volume, increased stroke volume also increases cardiac output. All right, now what if I increase EDV, this number here? So let's say I make this 150. 150 minus 50 is now 70. 75 times 100, we get 7,500 mils. So EDV going up, the amount of blood that we fill the ventricle with, usually means we're going to eject more blood out of the ventricle. And so that also increases cardiac output. The only one that will decrease it is this one because there's a negative in front of it. So let's say I increase this to 70 all of a sudden. So our heart is not working as well and more blood stays and less blood has been ejected. This number now goes down to 50, okay? And I can't do that math. That's like 3750 mils per minute, something like that, okay? I might be off a little, but it's much lower. Basically, the takeaway is that it's a lower number. Okay, so the one good thing is all of them increase cardiac output except one. So really what you could remember is ESV, if it goes up, it impacts cardiac output opposite. Cardiac output would go down. Now, this is, we can reverse all this. We can lower heart rate. If we lower heart rate, we'll lower cardiac output. If we lower stroke volume, we will lower cardiac output. If we lower EDV, we will lower cardiac output. So then in that case, if we lower ESV, we would raise cardiac output. So hopefully that makes sense. If you need to play around with this a little bit, plug some numbers in, make sure you understand what's going on, because a lot of times things that we do, neural regulation, and then later we'll talk about hormonal regulation, will impact one of these numbers, and that will then result in cardiac output going up. Okay? All right, so now what are some factors that affect EDV and ESV? The filling and how much is left in the ejection. Okay, so we have the Frank Starling law of the heart, named after a couple individuals who figured out this law. So they talked about a thing called preload. And preload is the degree of stretch before a muscle, of a muscle before it contracts. And so what this is saying is that the fibers have stretched. And so the actin and myosin is not overlapped very much, but it can go a very long distance to be contract fully. I'm going to come back to me for a second here and show you. So here's our, pretend our actin and myosin. These are actin and myosin fibers in a muscle, skeletal muscle. So normally they might be like this, and then when we contract, we can only contract that far, each sarcomere. Okay. However, if we really stretch, and we stretch so they barely are overlapping, we can generate more force total, right? Because we can go a farther distance. This would be like if you were going to try to like break down a door, and you were standing 1 foot away from the door, and you took your shoulder and you went boom into the door. You would have some force, and the door would probably not break. If you stepped back 5 feet and then got a running start and then put your shoulder into that door, you have a much higher chance because you've generated more force of breaking that door. Okay, so that's what preload is, the degree of stretch of a muscle before it contracts. Contraction, therefore, is more forceful when the muscle fibers have been stretched. So if we fill our ventricle with a lot of blood and we really stretch the ventricle out, okay, we will then contract harder and eject more blood. And that's why EDV goes up. The end diastolic volume goes up due to preload. We stretch the heart, stretch it out, we fill with a lot of blood, and then we can contract and eject a lot of that blood. And this is a good thing because it assists we can stretch or not stretch and kind of make sure that the amount of blood between the two systems is very equal by doing this, by kind of stretching too much or not stretching at all, and we can kind of balance out. Now there's another term, afterload. And so afterload is the load after blood has been ejected. So remember we said that we have to, when we eject the ventricle blood, we are going to have it go into the aorta. One thing we didn't remind ourselves of is there's already blood in the aorta, right? There's blood sitting there. That blood came back and closed the semilunar valves. So we have to overcome the pressure of that blood in order to get the blood out of the ventricle. Okay, does that make sense? So this is called back pressure exerted by the atrial blood on the aorta. So this tends to be 80 millimeters of mercury. And you might have noticed, I don't know if I said it, I'm going to go back to our book real quick here. We have this up still. So here was our dicrotic notch, and blood filled back in because of gravity, and then, here's our dicrotic notch where blood filled back in because of gravity, and you notice that it kind of drops off a little bit because blood is leaving the aorta and going someplace, but it never goes to zero. It actually, there's still blood in the aorta, and the pressure goes down to about 80 millimeters of mercury. This is our diastolic number of our heart blood pressure. So 120 is our maximal pressure that we measure. 80 is our minimal pressure that we measure. Now, if we were in the pulmonary trunk, it would be about 20 millimeters of mercury, or even maybe less, 15. So we have to overcome this pressure in order to get blood out of the ventricle. So this pressure must be overcome to get it out. So if this value, if this pressure is greater than normal, so that's normal. So let's say this pressure was 100 millimeters of mercury. We would have to overcome more pressure in order to get out the blood. And what will happen is usually we won't be able to eject as much blood. And as a result, ESV will go up. The amount of blood that remains in the ventricle will be higher because we aren't able to overcome the extra pressure. This is one reason why high blood pressure can be a problem. If you have a high diastolic number, right? Let's say your blood pressure is 140 over 100. That means that every time your heart contracts, it has to force blood out. And instead of overcoming only 80 millimeters of mercury, it has to overcome 100 millimeters of mercury to get the same amount of blood out. So it normally can't do that, and so extra blood stays in, which means that your stroke volume goes down. Remember, if ESV goes up, stroke volume would go down and cardiac output would go down. And that means that your heart's not as efficient. So your high blood pressure could cause less heart efficiency. Your heart might have to work harder, and your heart may fail at some point. You may get into a heart failure. Okay. Now, last thing, I made up a fun practical applications question about this next part. And I think for the sake of brevity, I'm not going to go over the practical application question. But what I'd like you to do is read this question now, okay? And then I'm going to talk about the autonomic nervous system for a few minutes. And then at the very end, and I don't want to go too far here, but at the very end, this same these same questions are here, and the answers are there. So what I would do is read this first thing, okay? And then listen to my lecture that I'm about to give, and then see if you can answer these three questions, and see how well you do, okay? Now, so we're going to skip that for now, but you can do it as your own little fun kind of review. So now that we know all that stuff, we want to talk about the cardiac output in terms of autonomic nervous system. And this is a main regulator of cardiac output because the autonomic nervous system can increase or decrease the amount of cardiac output through a couple different ways. Now you might recall that we had a cardiovascular center in our medulla. We talked about this in 231. And there was an acceleratory center, the CAC, the inhibitory center, CIC, and then a vasomotor center. And that's going to be discussed in a later lecture. So we're not going to discuss vasomotor center right now. We're just going to talk about CAC and CIC. Now the nice thing about these is they're named pretty well. The acceleratory center, CAC, has sympathetic fibers. These go out nerves T1 and T5, and they innervate both the SA and the AV nodes. They also innervate some of the myocardium. Okay? What they release is epinephrine and norepinephrine, and they have beta receptors. And you probably remember we mentioned there were alpha and beta receptors back in 231, but we never really talked much about them. Well, here's the time we're going to talk about them. So epi and norepi are released, and they stimulate beta receptors in these target areas, the pacemaker nodes and the myocardium. What does it do? Well, the first thing it does is that the SA and AV nodes increase the frequency of heart contractions. So if we stimulate this area with sympathetic stimulation, the beta receptors will cause the SA and AV nodes to increase their contraction rate. So heart rate will go up. They fire more frequently. If we stimulate the myocardium, the muscle itself, we'll get more calcium influx in the into the cytoplasm, and that's going to result in a greater contractile strength. Think about why. That'll expose more, allow more actin and myosin cross bridges to form, and that means we can get more contraction. And so if we get more contraction, our ESV will go down. The amount of blood that's remaining in the ventricle will go down because we're going to contract more. And so if we contract more strongly, then stroke volume will go up. So notice that this would both increases heart rate and stroke volume. So that can make things really high. So remember, originally we had 75 times 70 was our cardiac output equation, and it was 5250. Now let's say I mess with both of these. I go to 100 beats per minute and I go to 100 stroke volume. That's 10,000. That's almost a doubling. So we can really increase our heart rate, our stroke volume, and really increase our cardiac output. Okay. Now, I made a little note here. The SA node can also be affected by baroreceptors in the atrial wall. And so what's happening here is if the atrial wall gets very congested and we have lots of stretch in the atrial wall, we can have the SA node will also get noticed, okay, or will get signaled. And what that's telling us is there's a lot of congestion in the atria. And so if we have a lot of blood, it's in the atria, not enough's going down to our ventricles, we may need to beat more times per minute to push that blood out of the atria into the ventricles and back through the body. So if we notice that there is a lot of congestion in the atria, the SA node will be stimulated and by nervous system and will increase. Okay, and that will increase heart rate. Okay, so now let's talk about the inhibitory center. Guess what? It does the exact opposite. Makes it very easy. It has, instead of sympathetic, parasympathetic fibers. It goes through the vagus nerve. Remember, instead of going out thoracolumnar, it goes out through our cranial sacral, and in this case cranial, our vagus nerve, our main regulator of parasympathetic stimulation. They innervate the SA and AV nodes. They innervate some of the myocardium. They don't release acetylcholine, or they don't release epi and norepi. They release acetylcholine. What do? The exact opposite. Okay, so we'll do it in a different color. They're going to quiet the SA and AV nodes, heart rate goes down. They're going to decrease contractile strength, so at ESV goes up, more blood stays in the ventricles, that means that the stroke volume goes down. Okay. Now, another little side note here. There are baroreceptors also in the carotid sinuses in the aortic arch. All right, and so look at where these are. Here's our aorta, so there's baroreceptors there. Here's our carotids. There's baroreceptors there, okay? When these are stretched, when these guys sense stretching, okay, when these baroreceptors in the carotid sinuses and the aortic arch stretched, this would be due to increased atrial pressure, so our increased arterial pressure. This means our blood pressure is higher. We want to lower the cardiac output. We want to stimulate the CIC to lower cardiac output. Why do you think? Well, if our blood pressure is too high, especially to these guys, we're going to send a lot of high blood pressure to our brain. We want our brain to stay at a very regular blood pressure. We do not want the brain to get too much pressure. We can unfortunately have something like a stroke or a head bleed. So this is another nervous system response where a receptor in our vessels will then cause this, send a message to the CIC to lower cardiac output. Okay, so here's one where we could kind of release, this is just a review of some of the things we said. So if something increases your sympathetic system, like exercise, fright, anxiety, we're going to increase our CAC and decrease our CIC. We increase our CAC a couple ways. One is we can directly increase heart rate. That will increase cardiac output. Another thing we can do is stimulate the muscle to increase contractility. That lowers the amount of blood left in the ventricle. That makes stroke volume go up. Remember, if we increase stroke volume and increase heart rate, we get a really big cardiac output. Now, there are other things that can increase this, and there's some notes here about that, but we're not going to cover these right now. But there's some hormones, excess calcium, and even blood-borne epinephrine. Epinephrine as a hormone. We'll talk about that when we get to hormonal controls, but for now, we're not going to mess with that. Now that you've read those two things, you can go back to my original question here. There it is. Again, I just repeated the question. And on the next page is the answer. So you can read through this, see if you can figure out what is going on with this Michael. You know it's not me because I never wear a tie or a watch, but a fictitious Michael here. And you can try to figure out if you can answer those questions. Okay? So we went over a lot today. This was a longer lecture. They go together though, and it's a good way to kind of end the heart, because the heart has so many things happening. We need to know how the ECGs are, what's happening in that. That helps us know how the cardiac cycle works. That helps us know where blood volume is going from atria to ventricle. That tells us about stroke volume. That stroke volume tells us about cardiac output, how much blood is being ejected from the heart per minute. All of those things go together. So it's kind of nice to have this all in one package. I would recommend stopping the video, rewinding it, watching things again, making sure you take notes well, and then as always, ask your instructors for any help or clarification. Okay? Thank you.